We have achieved 1 million lens implants. We are STAR. And infinity is the next milestone.
Next is EK, that is our own session.
Right.
So this is a session on complex cataracts. No?
That's true.
So, and after we just say who are the moderators and who are the panelists, then we just hand it over to you, Dr. Ramamurthy and Dr. Partha Bishwas. I don't see.
Fine. I think we just go on with the presentations and have the Q&A in the end.
Yeah.
That's,
4 minutes only, no?
Yeah, because I think it's a very tough.
45 minutes, you have to finish everything.
It's just 4 minutes each, right?
Yeah.
All talks 4
Yes.
minutes.
Yeah.
Okay. Dr. Partha is here. Dr. Purinder is here. Hi, everybody.
Hi. Hi, everybody.
Hi.
Morning.
Dr. Barua, sir.
So are we live?
Not yet.
Hello, Partha. Welcome.
Sir, thank you, sir. How are you?
Good.
Hello, Dr. Partha.
Hi, Priya.
Partha, how are you?
Everyone, Dr.
Oh,
Priya, Dr.
great,
Jatpal,
sir.
Dr. Toshipal.
Navneet.
Hello.
The man with the books.
Hello.
अभी भी कितना पढ़ाई लिखाई करते रहता है नवनीत?
Shankar.
Do's and
SN.
don'ts. Do's and don'ts of emulsification. Dos, fantastic.
Thank you, thank you.
Hello everybody, am I audible?
Hello, everyone. Am I audible?
Yes, sir. Very much loud.
Yes.
And clear.
Thank you. Nice to see you all.
Same here, sir. Same here.
So you're looking down on all of us, sir, from Punjab, sir. Right up to Coimbatore, sir.
Oh,
Yeah, we are right at the bottom.
From north to south.
Are we waiting for something? Namrata?
Admin, can we start?
Yeah, already 5:33, 34.
5:34
Are
now.
we live?
Yeah.
Are we live?
No, I don't think so. Don't know.
I think I'll have to call up and
Ramamurthy sir, good evening.
Very good evening. Very good evening, Navneet. How are you?
Fine, sir.
You're in your clinic or what? Or at home?
No, he's sitting in the clinic.
Oh,
In between patients, in between
No,
delegates.
no patient in the evening.
I think Dr. Amit has just come out of his OT.
Yeah. So just did 4 cases today, only 4.
Good evening, doctors. Good evening, doctors. We are going to start a section. Dr. Maria, you can start your sections right now. Thank you.
Thank you. Can you hear me well?
yeah.
Yes.
Okay, well, good morning, everyone. Thank you so much for having me. It's always a pleasure to share every year, this time with my friends from India. So I'm going to describe a little bit about why the glue IOL technique is one of my preferred techniques for secondary IOL implantation in case of capsular support. As we all know, there are so many variables, and when we don't have a capsular support around the world, and there is still not consistent agreement on which technique is superior to another. The literature review, recently published, shows that there's no difference in terms of visual acuity outcome in the different techniques. Also, there is no testing, or data that will show the results about comparing the IOL centration and tilt. And the main reason of why I do prefer the glue IOL technique is just because it allows me during the surgery as a unique technique compared to the sutures, compared to the Yamani technique, is the centration of the implant. So as you can see, the step where you tackle the haptics into the scleral tunnels, this is what this technique is unique regarding all the other ones, because as you can see, allows me to manipulate the haptics until the appropriate and perfect centration of the implant. That will will allow a better visual acuity. Here I have different results, okay, of a comparison of the IOL tilt. These all are in my cases. So in the first case, in the first picture taken by scan biometry, you can see that's an IOL in the back. On the second case, you will see is that's the glue IOL technique, and you can observe the perfect centration of the IOL. The third one is a scleral suture that I performed many years ago before, incorporating the glue IOL technique. And in the last, in the bottom in the right, you can see how the centration on the tilt of an IIRSI suture IOL. So I think that that gives us an idea, that, on this technique, it's not just important to have the IOL fixed to some point, but also just to evaluate how the position of the lens that is so important for visual acuity. Thank you so much. And if you have any questions, just let me know.
Thank you, Dr. Maria, for that very nice presentation. I think we'll get over with all the presentations and have the questions at the end of the session, because we are quite tightly placed. May I invite Dr. Arup Bhaumik from Kolkata to present on
Dr. Maria, please stop sharing your screen. Can you see my? No. Please see the. No.
Yes, it is visible. Or go ahead, please.
So, good evening, everybody, and my topic is the snare. I have no financial interest. But snare I have already presented many years back, how to cut the raw cataract in SICS and removal the piece one by one. And also I presented how I can use the snare, how we can expand the single piece IOL out of the bag. So today I am presenting one such slightly different case. It's a hard brown cataract, which is a Morganian cataract. It's a very hard cataract. And when I'm doing capsular rexy substance Titan blue, I saw there's a zonular laxity. I was little complacent, and so what happened? I extend the rexis. So sometimes we go before our commitment, we make it so difficult. This particular case would have been better to do a SICS, but it's I committed for the phacoemulsification. I decided to go ahead with the phacoemulsification. And this is a very hard and loose cataract, and there is a laxity. I plan to do a anterior chamber phaco and bringing out the whole hard nucleus into the anterior chamber. And it's very difficult to crack, so I decided to use the snare to divide the hard nucleus into at least 2 quadrants, so that I can my energy requirement of my ultrasound energy will be less in the anterior chamber, so that I can save my few of endothelial cell of the patient. So after this elastic, I started my phacoemulsification, keeping my IOP of slightly is a higher side. I generally prefer to do surgery in the IOP is a maximum 40, but here I am doing 70 because there is a little bit of leak in the main port I saw, and I want a very good and deep anterior chamber. Somehow I able to emulsify that lens, but this lens, the cataracts was very hard and very difficult to emulsify that. Above that, I saw there is a lot of fluctuation of posterior capsule because of jonular dialysis on side, and I cannot put a CTR as because I already extended the rexis. Then I put one nucleus into the bag and one nucleus into the antechamber, emulsify half of the nucleus. Then I decided why not do a IIL scaffold so that the PC will be more safe position. So I implanted multi-piece lens into the sulcus, and I saw there is a lot of jonular dialysis, so the lens was now absolutely center, giving viscoelastic, and decided to cut the nucleus once again into the smaller half, so that requirement anterior chamber manipulation would be less in that particular case. So again, I cut the nucleus with the snare and continue my emulsification in high IOP as because I want slightly deeper chamber. The nucleus is very hard, and continue this case, and I just fast forwarding this case and able to complete the case without disturbing the vitreous. This is the last quadrant, emulsifying, and after removing the last quadrant, I just centered the lens into the sulcus and little bit of pilocarpine, and there is no vitreous, and I am able to say this is a one can use this snare in this way, so that hard cataract can be divided into the smaller quadrant before doing phacoemulsification. Thank you for your kind attention.
Excellent video, Arup. I hope we have time to discuss something at the end. I now call upon Dr. Arun Kshetrapal to talk about posterior polar cataract.
Can you see my screen?
Yes, yes, very well.
Good evening, everybody. Thanks, Dr. Amar, for giving me this opportunity. Why are the posterior polar cataracts so important? Yeah. So basically, posterior polar cataracts, they have a strong adherence of opacity, the lenticular opacity to the posterior capsule, which is weak in itself. And it's associated with a lot of complications. And 25, almost in posterior polar cataract, the rate of the incidence of posterior capsular rupture is almost 25%, which is quite high. And we can bring it down, of course, with our modification in the surgical techniques, and the incidence of nucleus drop is also more in such cases. So we need to modify our surgical technique in posterior polar cataract. What is required is gentle maneuverability, low parameters. We avoid hydrodissection because hydrodissection can cause posterior capsular rupture, and avoid rotation or the manipulation of the nucleus too much. Here I present a case of posterior polar cataract, which is about nucleus sclerosis grade 3 and with a pre-existing posterior capsular rupture. So, as the dictum says, no hydrodissection and no rotation of the nucleus. Make your capsular axis. The capsular axis need to be of appropriate size. It doesn't have to be too big in size or too small, because if it's too small, it will be difficult to maneuver the nucleus in small capsular axis, and the chances of fluid getting trapped is more with a smaller capsular axis. So So with low parameters, low flow rate, low vacuum, you remove the nucleus slowly. And if you can appreciate that there's a posterior capsular rupture behind the epinucleus. Here I'm removing the epinucleus. The another thing you need to do is you need to maintain the chamber stability. So whenever you are removing out your phaco probe out from the eye, fill your anterior chamber with viscoelastic. So up till now, I have been able to save the vitreous. There is no disturbance of the vitreous. Vitreous is still in the posterior segment only. But you can see there are a lot of opacities in the posterior vitreous. Before you tackle those opacities, it is always advisable, and if it is possible, to convert your posterior capsular rupture into a posterior capsular rhexis. The posterior capsular rhexis give you enough strength and avoids further extension of the posterior capsular rupture. And if you can appreciate, here I'm using my irrigation cannula to maintain the anterior chamber. You can use a good viscoelastic to do the same thing. Once you have made your rupture into a rhexis, it's time to remove all those opacities which are present in the vitreous. You can do it through the anterior chamber also, or you can go through the pars plana, as I have have done in this case, a 23 gauge vitrectomy through the pars plana, and you remove all the vitreous opacities. Once the vitreous opacities are out, and since I have a good posterior capsular rhexis, here I'm implanting a single piece IOL in the bag. Had my posterior capsular rhexis was not strong or it was big enough, I would have gone in with a 3-piece or a multi-piece IOL with a optic capture. But since I have a good bag and good posterior capsular rhexis, so I can go ahead with a single piece IOL in the bag. In conclusion, I'd like to say that posterior polar cataracts have a high rate of posterior capsular rupture during surgery. They are true challenge for the cataract surgeons, and different techniques are used to minimize and improve the final outcome in case of posterior polar cataract. Gentle maneuvering, avoidance of chamber collapse or overinflation, low parameters, and avoidance of hydrodissection, nucleus rotation, and posterior capsule are some of the tips which you must carry with you once you're doing posterior capsular rhexis, posterior polar cataract next time. And I must emphasize that sometimes even overinflation of the anterior chamber can also lead to posterior capsular rupture in cases of posterior polar cataract. Thank you very much.
Thank you, Arun. Wonderful presentation as usual. And now we go over to Dr. Purendra Bhasin. And Purendra is going to speak on phaco in post-RK eyes. Purendra. Unmute yourself, Purendra. Unmute, Purendra. Admin, can you unmute Purendra?
I have done it. Yeah. Thank you, Dr. Partha. At the outset, I would like to thank Dr. Amar Agarwal for giving me this opportunity. And I will be speaking on pulse for phaco in post-RK eyes. Because these corneas are irregular, even mild. Pardon me? Can you see my screen?
Yes, it's coming.
Yeah.
Fine.
Sorry. Thank you. So, because these corneas are very irregular, so even the mildest of the cataract will lead to significant visual disturbance to the patient. So, there are challenges in post-RK eyes, which is the first and foremost is the IOL power calculation, which is which is inaccurate in most of these cases. And these RK incisions create a challenge during the cataract surgery. Post-operatively, the recovery can be prolonged because of the wound hydration, and then it takes time for the cornea to settle down. Patients are demanding and intolerant to residual refractive error. This has to be kept in mind. So the problem is that in these eyes, the cornea is flat, both anterior and posterior surface. That's why, and there is a small central optical zone. And the effective optical zone diameter is smaller than the diameter of the standard keratometry, which is 3.2 millimeter, as you can see. So there is overestimation of the corneal power, and resulting in the implantation of the lower power IOL, and there is a residual post-operative hyperopia in all these cases. So this has to be kept in mind. So what I have observed in my case is that if I have implanted a less power IOL, say 14 diopters, 15 diopters, because these corneas tend to give us such kind of IOL power. So if we have this, so we should be careful enough, because I have seen that if we implant a 20 diopters or more power, then we are more close to the post-operative near neutral refractive error. And to prevent post-operative hyperopia, a more myopic result can be targeted, such as minus 0.75 diopter or even 1 diopters. And we should use flattest central K on topography for our IOL power calculation. This is my experience in all these cases. We should always use a flattest K. Multiple keratometry readings with varying diagnostic devices such as Pentacam or Galilei dual sham fluke analyzer can help us, or maybe we can use Varion. The power of cornea is a combination of both anterior and posterior corneal power. So Belloni has given a formula which is like when we can use a central corneal power on topography and multiply it by this factor minus 6.1. So this gives us an estimated corneal power, or we can use IOL calculator from the ASCRS or ESCRS website. Coming to the surgical considerations, these RK incisions are weak and are prone to opening during surgery. We should avoid cataract surgery incisions intersecting the existing RK incision, as they can unzip and cause excessive fluid leakage during the surgery. And we have to suture them at the end. To ensure safe surgery procedure, I prefer lower flow rate and a lower bottle height. I do scleral incisions, and I try to go as small 2.2 millimeter phaco needle and avoid 2.8 or more phaco incision. This is a video, as you can see, small video case with multiple RK incision, almost 16 or more RK incision. Capsular access, I'm doing it through the side port to avoid any leakage. And phaco is done. And as you can see, there is a scleral rear incision here. So there is a broad scleral rim which prevents the phaco to damage go into the corneal side and the unzipping of the existing corneal wound. As in all these cases, we have to maneuver because these chambers are deep. So we have to maneuver with the phaco tip or phaco handpiece. We have to go down. So there is a tendency to the existing phaco incision can go open up. Another case, there is a myth that due to the presence of RK incisions, the femtosecond laser cannot be done because the capsular access will be incomplete in that area. I have done a couple of cases with this femtosecond laser, and I don't find that there is any problem in the formation of the capsular access in such cases. So, and rest of the things are same. So I will show another case wherein a PC polishing in these cases is very important, and in-bag IOL. Wound hydration, nowadays I don't hydrate because this can also lead to the opening up of the incision at times. In this particular case, as you can see, my incision is not scleral. So the existing RK incision has opened up, unzipped, and there is a leak here. and the iris is tend to come out through this incision. So, but I was lucky enough that it was not very wide, and it has been plugged by the iris. So after putting the IOL, I will suture it transversely, as well as the main wound also will be sutured, and this can be removed after early post-operative period. So one can use intraoperative aberrometry to overcome the problems associated with IOL power calculation. Post-operatively, the arc incisions swell even after the gentlest cataract surgery, inducing central corneal flattening, resulting in hyperopia and immediate post-operative period. So we should wait for at least 6 weeks before we prescribe glasses, or we take a chance to exchange the IOL if there is a large amount of residual refractive error. And all this depends on the number of arc incisions which are preferred. I personally prefer single focus lens implants. Aspheric IOLs may be a particularly good choice in these patients because of their significant corneal abrasions which these RK corneas have. And multifocal lenses should better be avoided for the reason that cornea is irregular. It is difficult to achieve absolute or near emmetropia, fluctuation in the refractive error, which may be diurnal also. There may be progressive hyperopic shift over time, and they may sometimes require keratoplasty. So, dear friends, we can do phaco in post-RK eyes, and we usually do it, but we should take with all these precautions. Thank you.
Ravindra, thank you very much. And now we go over to Dr. D. Ramamurthy. Sir is going to tell us about IOL exchange.
Ravindra, can you please stop sharing?
Yeah. Thank you.
Thank you. I have a fairly straightforward topic on IOL exchange. What exactly could be the reasons for an exchange being necessary? It could be a grossly missed target. If it's a small errors, obviously a laser vision correction would do. But otherwise, larger errors, especially if it's hyperopic, then exchanging a lens would be a good idea. Significant dysphotopsia, malpositioning of the lens, patient dissatisfaction for various other reasons could be causes for an IOL exchange being necessary. And as far as the IOL power of the new lens is concerned, there are various ways of determining that. Usually I use more than one modality and compare them. One is, of course, using the biometry in the pseudophakic mode. Other is a simple way of whatever be the residual error. If it's on the myopic side, just multiply it by 1.2 and add it to it. If it's on the hyperopic side, then multiply by 1.5 and add it to it. And you also have the Barrett RX formula. I use that especially when there is a toric intraocular lens involved and I need to position a new lens with different toricity and orientation. This is a fairly old video of mine about 12 years back when the way I am exchanging this lens. Ideally, these lenses are exchanged, especially if it's a single piece hydrophobic acrylic lens, within 2 to 3 weeks, because otherwise there could be a significant amount of tackiness. As you can see here, I'm cutting the lens into 2 halves, and you can see the significant rotation that takes place at the eyeball. This is done under topical anesthesia. Basically, I'm showing this to tell you that this complete bisection of the lens is really not necessary, though it's still practiced. It looks like it's a little unnecessary. And of course, you can take the lens out through the same opening and implant the right powered lens into the eye. Today, my preferred choice when an explantation becomes necessary is essentially this, where I go ahead and just create a small nick on the lens. It's actually a quarter cut on the lens. And then with a hand over hand maneuver, you can go ahead and expand this lens. Usually I bring out one haptic outside, hold on to that stabilizes the lens quite significantly. You can see compared to the other video that you saw earlier, this eye seems to be much more stable. I think prolapsing out one haptic and getting a hold over that helps you. But it's a 3-piece lens. Sometimes that haptic tends to come off. So it might be a good idea to hold the lens with through a microforceps. I'll show in a subsequent video. That's the lens coming out and a new lens being implanted through the same opening. And no enlargement is necessary, and it's really not necessary to bisect the lens quite completely. Over here, you have a multifocal Indian multifocal intraocular lens that has been implanted. The patient had somewhat of a subluxation of the lens in the back, but the lens appeared to be in the back. Twice I repositioned the lens. This case had actually been referred to me, but then still there was a tendency for the lens to move away every time. So I decided to go ahead and reposition the lens, or reposition the lens. But when I tried to do that, this was the reason why the lens was not remaining in position. Ideally, the earlier surgeon should have informed me that one of the haptics had got cut. This lens is never going to stay in position because the haptic support is not there. So you can see over here, I'm introducing a micro forceps to stabilize the lens. Again, it's just 1/4 cut of the lens that's done. And with the hand over hand maneuver, then you can remove the lens through a 2.83 millimeter incision. Ideally, sometimes the lens does get while you're removing it, but then helps you to re-implant the power of the lens of the right choice. In this case, the same multifocal implant lens was implanted. And you can see, and this is another situation where a multifocal intraocular lens had been implanted. Years later, the entire lens with the bag had got subluxated. And since it was a single piece lens, there was not a question of fixating this lens on. If it is a 3-piece lens, I might have tried doing that. So essentially, the entire lens with the bag comes out. And subsequent to that, I go ahead and implant a 3-piece multifocal intraocular lens. Here, essentially, you can see my vitreoretinal surgeon separating the capsular bag from the around the lens, and then subsequently the lens in toto is brought out, and then we use it's a 3-piece multifocal lens with a +4 diopter add that goes in. The patient was enjoying an excellent multifocality for a period of almost 10 years and was not willing to compromise that, and had a multifocal in the other eye. So using the classical scleral fixated intraocular lens technique, glued IOL technique, this lens is fixated. So you can see this was the preoperative position where the entire lens with the bag has got subluxated. 1 day post-operative, and this is the lens which is reasonably well fixated. Obviously not a great way to go, but then sometimes when you're faced with this situation, and if you can fixate the lens as was shown adequately even in the first presentation, even in these cases a multifocal intraocular lens does do well. Thank you so much for your kind attention.
Thank you, sir. Thank you very much. And now we'll go over to Ashiana Nariani, and Ashiana will speak to us on open sky cataract. Ashiana, please.
Thank you very much. Can you all hear me?
Yes.
Great. So hope everyone is safe and well. I have no relevant financial disclosures. Combining penetrating keratoplasty and cataract surgery into a single procedure is beneficial for patients with advanced cataracts and severe corneal opacities, but the risk here is your suprachoroidal hemorrhage and your anterior capsular radialization, which is why it is important to ask the question, is it necessary to go open sky? And if any of these potential scenarios is relevant, definitely use all of the techniques possible to help you. And here are some of the techniques that we're going to go through today. So techniques to help maintain a closed anterior chamber. Number 1, an illumination system, either externally or internally. Here's an example of a 20-inch dual illuminators system inserted into the vitreous cavity transconjunctivally. We can appreciate the excellent visualization of the anterior capsule. And of note, this paper showed that 29 gauge compared to 25 gauge improved the visualization. On the right, you can appreciate for the interlaced triple procedure, 2 major differences. Number 1, that a diathermy was used to establish your anterior capsulotomy. And number 2, that after the corneal button was then replaced, did an intraocular lens did an intraocular lens become inserted, and this was after 8 sutures were placed. Alternatively, what can be done is all of your sutures can be placed and a secondary wound can be made and established in order to place your intraocular lens. Now, if you have to go open sky, use the IRIS to help you. And so here's the IRIS-assisted capsular rhexis technique. In order to prevent the, in order to do this, do ensure that you keep the iris in its physiologic state undilated. And so the iris can be used to counteract the forces of the radialization. Now, if you do experience radialization, you can stop where you're at and then just use a second capsular rhexis in the alternate direction to help you. Additionally, new stains are out there for anterior capsular visualization. And here in this paper, you can appreciate that a combination of trypan blue and BIP at 0.015% establish the best visualization of that anterior capsule. Now, hope for the best, but plan for the worst. Pre-planning is critical. So in terms of a triple procedure, ensure that you already have your incisions made for a secondary IOL should it be required. This is going to establish your incisions on an eye that is not hypotenuse, number one, and number two, it's going to allow for you to spend less time open sky. Thank you very much.
Thank you for that lovely presentation, a difficult scenario, very well handled. And we have the final presentation from Dr. Partha Biswas, who's going to be speaking on spherophakia. I think we're pretty tight on time, but after Partha's presentation, I would request each of the panelists to comment on any one of the presentation that happened.
Thank you, sir. Thank you very much. I present a case of spherophakia, and these cases, these spherophakia cases came to us, and over the last 10 years, they taught us so many things, and the technology has improved. And this was about 8 years back. And a spherophakic cataract, as you can see, and the bag is so difficult to maneuver. We can just not get a capsulotomy done. The puncturing of the anterior capsule is so difficult. And thereby, we try and puncture it with a 30-gauge needle, and over that, with a forceps, with a micro forceps, carve out very patiently, and it took nearly 15 to 20 minutes to get that rhexis right. With the rhexis done, the spherophakic bag is there in place. The iris hooks hold the spherophakic bag, and we put an intraocular lens, a single-piece intraocular lens inside. But of course, the bag has to be supported. And in goes 2 Ahmed segments. And these 2 Ahmed segments nearly envelop the whole of the periphery of the bag. And thereby, requirement of a CTR is just not there. The Ahmed segments pull it apart, and optimally secured, we have the spherophakic bag nicely in place. This is the first child whom we did, a 23-year-old young lady, in fact, and the spherophakic bags stayed stable. About 8 years later, she comes in again, and this time it is her sister who comes in with, again, microspherophakia and cataractus changes. The intraocular pressures are fine, and we remember from this child the trials and tribulations that we had with spherophakia. But this time we have a new machine in the armamentarium, and we use the femtosecond laser cataract surgery for this patient. And we go ahead, and you can see the spherophakic cataractus lens over there, and we do off capsulorhexis. We do not require a side port in this patient, and we'll do the side port manually. But the capsulorhexis is the most important part of the whole procedure. And this is what had taken us so much time in our previous procedures. And now we carve a Hoffman's pocket, and with a Hoffman's pocket in place, we are going to use the Ahmed segment as in the previous time and have the lens nicely positioned. The most important part of the whole procedure is the capsulorhexis, and you can see it's not free floating definitely, and it is a little posted stamped, but we are able to get a neat and round rhexis right dot center on the spherophakic lens. With that done, the rest is quite simple, and it's a gentle hydrodissection and removal of the cortical matter as well as the very, very soft nucleus matter from the spherophakic bag. The iris hooks are best there, and they help the spherophakic bag to stay in place and give us the protection that is required. The intraocular lens, again, that is chosen this time is a single piece intraocular lens, and that goes inside the spherophakic bag. And you can see that the beautiful flexibility of the haptics are so good that they stay well curled in the spherophakic bag, well in place. The Ahmed segments, again, the positioning of the Ahmed segments, the suturing itself is not so difficult, and it is to hold this bag in place. Otherwise, the laxity of the zonules of the bag would not leave it in place, and at times the bag can prolapse right into the anterior chamber if it has not been well secured. So again, the Ahmed segment, as you can see, envelopes the whole of the bag's periphery, and it is nicely in place. With the Hoffman's pocket, of course, it is a little more elegant, and we have much less to think about post-operatively. This is the well-centered bag, and these are our two microspherophakic sisters smiling, and every time they come to us, they leave us with a smile. Thank you very much for your patient hearing.
Superb surgery, Partha. I mean, truly you showed the change that occurred over the generation. I wish we had more time to discuss these beautiful presentations that we had. Now, may I request our panelists to comment on whatever case they choose. Could I request Dr. Amit Tarafdar to say a few words?
Yeah, actually, I'll talk about the case with RK and cataract. We had some experience, few patients we had, and I found that with the IOL Master 700 and Universal 2 formula with TK gives us very good results. And any comment by the other people?
I quite agree with you. I also use the IOL Master 700 and also the Barrett formula, and usually the results are pretty reliable. And of course, it also depends on the number of incisions that you have and how close to the central optical zone that incisions are. Inaccuracies are still possible. And I always go for the highest plus power, hyperopic power, and usually it works out.
And if you give the incision little behind the limbus, like 1 to 2 millimeters behind, I think you avoid some risks.
Absolutely. I think Purendra also showed that very well.
Scleral incision should be, the choice of incision should be scleral.
Can I ask Dr. P.S. Barua to say a few words?
Yes. Thank you very much for giving the opportunity. I have a comment for three things. First, in RK, we should apply BCL at the end. Instead of hydrating and over-hydrating and opening the incision, we should apply a BCL for 2-3 days. Second is about glued IOLs. When we do glued IOLs, my posterior segment surgeon is always there. He looks after the vitrectomy, then we do glued IOLs. Third is when we are doing scaffolding, especially the case we shown, IOL scaffolding. I feel one should not try to put the lens into the sulcus. First, one can implant into the AC, do the phaco after scaffolding, then shift it to the sulcus, which will not be as difficult, because in such a situation to put the lens into the sulcus before FICO is difficult. So these are my 3 comments for 3 papers. Thank you.
Arup, would you like to respond to that? Just a brief comment.
Yes, this is a technique. We can keep one haptic outside the section corneal port, but in that case, there may be a lot of fluctuation. AC leak will be more, and there is a lot of fluctuation, and AC depth which is required will be less than what we did this particular case. So if you think your sulcus is okay, you can keep, and the capsular support is good enough, you can put your IOL in the sulcus and redo the FICO. But if you think your sulcus is not, your capsular support is not good enough, you can anytime drop, then definitely you can put one haptic in the sulcus, other haptic in the outside the corneal section, or even after iris and after doing FICO, you can implant other haptic in the
Thank
sulcus.
you. Thank you.
Navneet
Dr.
is there.
Navneet Kushewal? Sorry, Partha.
No, Navneet is there. Navneet.
Yeah, Dr. Navneet.
Regarding the IOL exchange, sir, are you having any experience of the micro scissors which can cut these hydrophobic lenses very well?
Yes, yes. Yeah.
Because in this video, I have seen the big scissors. So I was thinking that, are there any micro scissors to cut this? So that will be the less traumatic.
I think, yeah, especially
Yes.
the serrated ones seem to cut much better.
In fact, there's a pair of instruments. One is a holder, one is a cutter. So,
yeah.
So one of these ports, you stabilize the IOL, with the other hand, you cut with the serrated scissor, which is supplied one of the very good companies. So
Actually, IOL cutter, there is a different kind of IOL cutter. There is a particular IOL cutter for silicon IOL and a different cutter for the hydrophobic. There is a double hinge cutter. That is come with a one holder and a cutter.
Yeah.
But there is another cutter developed by the David Chang. There's a stout, very small blade, but very stout one. The Katina is making these. That is a very good. You can cut through your side port also. But for the double hinge, you need to a slightly bigger incision. I think double hinge cutter is very good.
I think.
I want to share one with permission of Dr. Ramamurthy, Namrata, and Partha, and of course with the permission of Dr. Amar sir. This third book, Do's and Don'ts in Phaco Surgery, forwarded by Amar sir and Dr. Majid. Yesterday only I received the hard copy. It has been translated in the French language, and this is going to be in a French countries, and this is all due to the great encouragement from the great people who are in front of me. And of course, this conference has given me all the time encouragement to inaugurate book. And this is the French translation of my third book. This is just I wanted to share here, sir. Thank you.
Hearty congratulations.
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 Congratulations to you.
Arun Baveja, any last comment?
I think we don't have Arun, but we didn't get a comment for Arun Kshetrapal's very nicely shown video and the posterior capsular axis that he showed. Very nicely done, Arun. And the only thing is not all posterior polar cataracts behave similarly, and usually it tends to rent right from end to end. And there you cannot do a posterior capsular axis. So you have to resort to the sulcus and put a 3-piece IOL and maybe capture it on the optic capture on the anterior capsule.
So the size of initial capsular axis is very important in such cases. So you need to make your capsular axis, the anterior capsular axis, such that you can capture your optic later on if required.
Quite true.
Thank you.
And
I think we need to end
We
this
need to
session
conclude now.
Yeah, we need to conclude
Because the next session speakers are already there, and we are running slightly behind.
Thank you.
I'm sorry
Thank
about
you.
that.
Thank you so much. Thank you.
Thank you to all the speakers.
Thank you.
Thank you very much.
Next time we will meet in presence.
Yes, sure.
Yes, of course.
Stay safe. Stay
Thank you,
safe. All
doctors.
of
We are going to
Thank you.
play a small sponsor video.
I
And
would
right
like to.
after that, we are going to start with Catherine Colby. Thank you.
Welcome everybody to the next session, which is on endothelial keratoplasty. I have my co-moderator with me, Dr. Benny Jeng, and panelists Dr. Vishal Khan, Dr. Sophie Dang, Dr. Barry Lee, and Dr. Terry Kim. And it is my pleasure to ask Dr. Catherine Calby, who is the president of Cornea Society International, to give her talk on DSO, desmoid stripping only.
Well, thank you, everyone. It's a beautiful fall morning in New York. I'm honored to be a participant in this exciting symposium. I'm going to talk briefly about desmoid stripping only. I have no relevant financial disclosures. I will discuss an off-label use of medicine and a non-FDA approved medicine. So we've known for a number of years that the endothelium in Fuchs dystrophy.
Catherine, can we have your slides, please?
Yeah, I'm looking at them.
Okay. So can we stop sharing this, admin? Yes.
Yeah.
Yes. Catherine, you can share your screen now.
Okay. Are you seeing that now?
No, we are not.
Okay, I'm pushing share screen. Well, you can see me, right?
Yeah.
Yeah, so
okay.
Share screen and then presentation.
Yeah, I'm now sharing and there's my presentation, but you're not seeing it?
No, don't see it.
You click to a presentation and then share.
Yeah, I'm seeing it. You're not seeing it. Why don't, well, you know what? I can actually just give my presentation quickly without the slides because it's a short presentation. So unless you want to do something else, Namrata.
Okay, we could do one thing. If you could just email your presentation and we can take the second talk. Benny, what do you say?
We can do that. I sent in mine pre-recorded to avoid any AB problems. So if
okay, Catherine, can you email your presentation meanwhile? Sorry.
Yeah, I'll email it. Yeah. Okay. Sorry about that.
If the administrator has my talk, you can put it up. It's pre-recorded.
Can we have Dr. Benny Jeng's talk on desmoid stripping endothelial keratoplasty? Admin, it's pre-recorded.
If not, I can pull it up and I can share my screen and just pull it up.
I think Benny, you share yours because they are not responding. Yes, perfect.
Okay. All right. Well, we'll go ahead and play this. This is 4 minutes long.
Thank you, Amar, and the organizers for inviting me to participate in the meeting. I'm pleased to be able to present in this symposium today on SEC. I have no relevant financial interests. So the concept of posterior lamellar keratoplasty is not a new one, like most things in ophthalmology. This concept has been around since the 1950s. It's just that up until the 1990s, the late 90s, the early 2000s, this procedure, or the concept of this procedure, was never really well executed. But since the time that Melis and Terry and others have come to light with this, there are now 2 current procedures that we do for endothelial replacement surgery. One is desmoid stripping, automated or not, endothelial keratoplasty, which is DSEK or DSEG. And the second is desmoid membrane endothelial keratoplasty, or DMEK. I have DSO on here, desmoid stripping only because it is an option for certain scenarios, but it's not truly keratoplasty per se. And this is not reflective of the rest of the world. In the US, almost a decade ago, endothelial keratoplasty overtook penetrating keratoplasty as the most commonly done corneal replacement surgery. Again, not necessarily across the world, but certainly in the US. And many surgeons are turning towards DMEK as their preferred choice. Despite DMEK popularity, DSEK is still very important in the corneal surgeon's repertoire because not all cases of endothelial dysfunction are best treated with DMEK, or DSO for that matter. And these include multiple tube shunts or any form of aphakia, whether it's true aphakia, ACIOL, or suture PCIOL, hypotony, or large defects in the iris, especially in the setting of some sort of aphakia. So what I'm going to do in the next 2.5 minutes is give you 7 things to keep in mind that will help with DSEK successes. Number one is not to do thick grafts. We used to do up to 200 micron grafts. At this point, you should be doing ultra thin or nano thin if you're going to do DSEK, because studies have shown that best corrected visual acuity, the speed to that, best corrected visual acuity, as well as graft rejection rates all favor thinner grafts. If you're going to do DSEK, then don't strip the wound unnecessarily right by the temporal wound. So I still strip slightly smaller than the graft, and the area that you want to avoid is right here. You don't want to strip this right in front of the wound because it will lead to microcystic edema and discomfort for your patients until the endothelial cells replace that area. I do a lot of surgery with tubes. The idea is if you can't put the tube into the back of the eye behind the iris, then you really should cut it as short as possible so that it does not interfere with the graft and allows for the best longevity possible. This seems really obvious, but if you're going to do something, you should do it well. And so for DSEK, I recommend learning one technique very, very well. I use the endosurgeon in general because I find it easy to teach residents and fellows how to do this procedure. But this is only one of many things in the armamentarium that I have to do DSEK. I think that it's important to know how to do folding technique with the forceps. I think that the sheath glide technique, and this is courtesy of Barry Lee, is very effective and can be done in a very cost-effective manner. This technique is the Tan Endoglide. I borrowed this from Donald Tan, also a good technique to know. And while this technique is my video, the concept of a suture pull-through leading to a retention suture that's already pre-placed, I learned from Elmer too, and I wanted to give him credit. But in addition to the main technique I do, I think it's very important to also know other techniques as well. Post-operatively, right when you're still on the table, if during the 10 minutes that you're waiting for the bubble to work, if the graft moves, then suture it. Because if it's going to move during those 10 minutes, then it's going to move post-operatively. If you're going to put a stitch in and use a retention suture, I advocate putting it inferiorly because it will hold the graft there while the air bubble works superiorly when the patient is sitting up. And always only put one suture in because otherwise it'll put a crease in the graft and you'll have non-adherence on the sides. If you keep these things in mind when it's necessary to do DSEK, you will have better outcomes and fewer complications. Thank you and good luck.
Thank you so much, Benny, for that wonderful presentation. Do we have Dr. Catherine Colby's presentation? I think they've already got it. They're just downloading it. So meanwhile, we'll go on with the next presentation, which is by Dr. Rajesh Sinha, EK with glued IOL and fourth row pupilloplasty.
Thank you, Dr. Namrata, and I would like to thank team IIRSI and Dr. Amar for having me in this webinar. I'll be talking about endothelial keratoplasty in aphakia. By aphakia, I mean that there is no adequate capsular support even to put the lens in the sulcus. So there are various issues in such aphakias. There can be issue related to refractive correction. There can be issue related to suboptimal tamponade because the air has a tendency to go behind it if there's nothing behind. A tamponade is also not adequate. There's risk of lenticular displacement. And many times you have this iris damage for which you have to do anterior segment reconstruction. And when you do that, then the risk of AC reaction is there. And for all these reasons, sometimes the DMEC procedure or the PDEC procedures can be a little challenging in these, however doable, but a little challenging. So ultrathin DSEK is a good compromise between the good outcome as well as the ease of doing the procedure. And people have modified various ways. They have used sutures to maintain the DSEK lenticule in position. The best thing is that if you can put an IOL so that there is a counter push to the bubble up so that the lenticule is pushed in position. So that is the best thing. And if the anterior chamber is very deep, iris is good, everything is fine, then one may think of doing an AC IOL, but the best thing is a scleral fixation of IOL. And that is the best technique. And the technique done by the intrascleral haptic fixation of the glued IOL technique provides a good stability of IOL. You can see this ultrasound biomicroscopic study, which shows that with movement of eyeball, the IOL is quite stable, quite steady, and it's not moving at all. So ultra-thin DSEK with glued IOL technique, which is being done here, is a reasonable technique. It's a good technique to provide good outcome in cases of aphakia with endothelial decompensation. So this is the posterior lamella that has been created, and then I'll just move fast due to paucity of time. So the flap is a lamellar flap, and an intrascleral groove is being created on both sides so that you can fix the IOL. Then this is the epithelium debridement to improve the visual, improve the visibility, and then scoring of Descemet's is done, and then the incision is enlarged. In this case, there is a lens which is decentered and touching the endothelium, so that has been replaced with a multi-piece IOL. The one haptic has been held, and it is being exteriorized on one side, and the other haptic will also be exteriorized on the other side. And then both the haptics will be tucked into the groove adjacent to it. And then once this is done, the DSEK lenticule is placed in position, and air is injected to place this is in position. Sometimes you have a bad traumatized iris which needs the reconstruction, and this is the DSEK lenticule with SFIOL, and the single pass 4-throw pupilloplasty provides a good outcome in such cases. This was one study published in JCRS, glued IOL with DSEK. And we performed another study wherein we divided all the stages into 2-stage and single-stage. We compared the two groups, and two-step technique. The first stage, we did intrascleral fixation of IOL, saniculators, and iris reconstruction. And second stage, ultra-thin DSEK was done in single step. We did all together, and we found out that there was procedural ease in two-stage technique. Rebubbling was more in single stage. Graft survival was better in sequential, that is 2-stage. And of course, in all these venting incisions required, I'll skip this. And this is one post-op picture. So in conclusion, ultra-thin DSEK in aphakia is challenging, but the glued IOL or the intrascleral haptic fixation provides a stable IOL. There's negligible risk of lenticule dislocation. The single pass 4-throw pupilloplasty provides a good iris configuration, preventing air to go behind the iris so that the tamponade is provided. This is one indication wherein I do stab incision so that the lenticule remains in position. And in some cases, rebubbling may be needed, as was required in the study. Thank you very much for your patient listening.
Thank you, Dr. Sinha, for that excellent talk. I think we're ready now for Dr. Catherine Colby's talk on Descemet stripping only. Professor Colby?
Yes, hello. Thank you. Sorry about that, everyone. So it's a pleasure to be here. I'm not sure I'm controlling my slides. Can we move forward one, please? I have no relevant financial disclosures. I'm going to discuss off-label use of Notarsidil, and Riposidil is not FDA approved at present. Next slide, please. We've known for a number of years that we can rejuvenate the endothelium in Fuchs dystrophy by relying on repopulation of the central epithelium by peripheral endothelium that is less affected by the disease after either cryotherapy or physical removal of the central Descemet membrane and endothelium. My first DSO patient is now 6.5 years out. He still maintains 20/20 vision and about 1,000 cells per square millimeter of his central endothelium. Next slide. The main tip is to pick the right patients. As Dr. Zhang alluded to, they have to be symptomatic from Fuchs, and the central guttae need to be no more than 5 millimeters in diameter with a preserved peripheral endothelium. Additionally, it's important that patients are willing to tolerate reduced vision for 3 to 6 weeks after the Descemet stripping, and also willing to undergo endothelial keratoplasty if the DSO is not successful. With that in mind, you'd like to avoid monocular patients, patients who have advanced Fuchs, for example, limbus to limbus guttae, patients who expect perfection, and patients without symptoms. Next slide. The ROCK inhibitors have been shown to improve the success rate as well as the speed of healing following Descemet stripping using anecdotal case reports and small case series. There are several approved around the world for glaucoma. In vitro, we know that this causes endothelial proliferation and corneal clearance in animal models. Maloney from Australia showed first that it could rescue failing DSO in 2016. And Marion Maxey from Chicago did the first investigator-initiated randomized trial showing that not only did a ROCK inhibitor improve final cell count, but it also sped the time to resolution of the edema. There's been a single case report of nitarsidil, which is the ROCK inhibitor improved in the US. Next slide, please. Here's a patient of mine who obtained Repasidil online and used it after her Decimase stripping. She cleared very quickly and her final cell count was about 1,300. She's continued to do well. Next slide. At present, we don't have a lot in the peer-reviewed literature regarding use of ROCK inhibition. There's a small number of cases, but many more have been presented at meetings like this. And I count we're up to about 230 cases of DSO with Repasidil. Next slide, please. Finally, while anecdotal evidence is nice, the way to prove that something works is to do a randomized clinical trial. We are currently enrolling in a multi-center, multinational, randomized, placebo-controlled, triple-arm study of Repasidil, which is the Rho kinase inhibitor approved in Japan. There are very strict enrollment criteria. Patients are enrolled after surgery if the Decimase stripping meets within rigorous guidelines. The main endpoint is endothelial cell count at 3 months, and there are multiple exploratory endpoints. We will do a larger phase 3 trial pending outcomes. COVID has interfered with our recruitment here. We do have 22 sites up and running and 2 patients have been randomized. Next slide. Again, Decimase stripping only, we've come a long way from 2016 when I first started talking about this to the dismay of the corneal audience. It's successful in up to 100% of patients in recent series. Clearance time improves with a ROCK inhibitor, and as well as a Rho kinase inhibition may turn non-responders into responders. We still have many unanswered questions, which we hope our randomized clinical trial will address. Thank you very much, and please stay safe, everyone.
Thank you very much, Dr. Colby, for that excellent presentation. Our next speaker will be Dr. Rajesh Fogla talking about DMEC.
Thank you, Benny. I'll just share my screen. Good evening, everybody. The evolution of endothelial keratoplasty, I think the previous 2 speakers have already alluded to. Currently, DMEC or ultra-thin DSEC are the most popular techniques. And if you look at the practice pattern by the Eye Bank Association of America, you will note that there is an increasing trend towards surgeons performing DMEC. DMEC is minimally invasive. It doesn't require any expensive instrumentation, does give a faster visual recovery with minimal refractive shift, with reduced risk of rejection and better utilization of donor tissue. So in terms of donor preparation, the tissue can be either prepared by the surgeon himself or herself, and it has a good reproducibility rate after you overcome the learning curve, or you can have the pre-stripped tissue from the eye bank or a patient-ready donor DMEC, which is already pre-stripped, pre-stained, and pre-loaded into a glass injector. Ideal age of donor is between 50 to 70 years. The F or F stamp is marked to identify the donor orientation, and the trypan blue dye staining is done to improve the visualization. Ideal case where the visibility is adequate, it should have a normal anterior segment without large iris defects or aphakia, intact lens iris barrier, and initially maybe avoid eyes with traps or tube or vitrectomized eyes with deep anterior chamber. The Decimase stripping is pretty much similar to what you do in DSEC, except that you strip a little larger than the size of the donor. You can do it under cohesive viscoelastic or using air fill or using an AC maintainer. and avoid creating an irregular internal surface. Inferior peripheral iridectomy is essential because you keep the air or gas tamponade for a longer period of time. This can be done preoperatively using the YAG PI or intraoperatively using the vitrector or a surgical PI. Various injectors are there, either glass or plastic, which can be used to deliver the donor DM into the eye. And once the stained donor graft is inserted into the eye, you can secure the wound using sutures to ensure that the graft is not expulsed from the eye when you are doing the manipulations to unfold it. And the manipulation is usually like a no-touch technique using tapping on the corneal surface. And this creates fluid waste within the anterior chamber. And this can be helpful in unfolding the graft. And having the S stamp tells you that whether you have opened it up in the right orientation or not. And once it's in position, you can secure it using an air bubble or a non-expansile mixture of sulfur hexafluoride. Post-operatively, you watch out for any rise in intraocular pressure, and the air or gas bubble should clear the inferior peripheral iridectomy to avoid a pupillary block. Be careful what kind of IOL you have, because a hydrophilic IOL may be prone to developing opacification. So usually we try to use myotics to constrict the pupil to minimize the contact of the air or gas with the intraocular lens. The recovery of the edema is pretty fast, and usually within a week you can have patients with clear corneas. And that's one of the big advantages of doing a DMAC surgery. One of the problems which is more frequent than doing a DSEC is that you can have donor DM detachments, and the rates can vary anywhere between 8 to 12%. Looking at the orientation of the edge of the scroll can tell you whether you placed your graft in the right orientation or not. And if the detachment and the edema involves a central area or greater area than 30% of the cornea, you can consider doing a rebubbling, which is very effective in restoring the corneal clarity. A report by the American Academy of Ophthalmology, where they compared the outcomes of DMAC, show that it surpasses the outcome of DSEC, both in terms of rate of visual recovery, the final number of patients that achieve 20/20 or better, and the risk of endothelial rejection. So in conclusion, there are several advantages of DMAC over other techniques of endothelial keratoplasty. The faster visual recovery, better quality of vision, minimal refractive shift, and reduced rejection rate. It makes DMAC an ideal procedure to manage endothelial disorders. Thank you. Thank you for your patience.
Thank you, Dr. Fogla, for that excellent talk. We'll move on, and our next speaker will be my co-moderator, Professor Namrata Sharma, talking about intraocular OCT with DMAC and PDEC. Namrata, you're on mute.
Okay, thank you, Benny. I would be talking to you about how IOCT helps in the surgeries of DMAC and PDEC. There are no financial or proprietary interests, and in India we have to prepare our own tissue. So the surgeons generally prepare the tissue, and when you are actually stripping the Descemet's membrane, you can see the way on the IOCT how it is stripping. And sometimes if there are any adhesions which are present, those also can be seen on the intraop OCT. Now, after stripping the tissue, it is again laid back in position. And then subsequently, trephination, the punch, 3 millimeter punch is used to trephine this area. A S-shaped stamp is marked on it. And again, the part of the plate that is there and put aside is put back onto this area. And subsequently, the graft is punched, which is about 8 millimeters. And then one can also see the orientation here itself, and can also see on the IOCT, so that when you load this into the injector, you load it exactly in this configuration. Now, this is a case in which the cataract surgery has already been done, and a case of fixed dystrophy. And when you strip the Descemet's membrane, again, if there are any Descemet membrane remnants or tags, these can be seen, and these can be removed, and the graft is then held inside the injector, is placed intracamerally into the anterior chamber. And then subsequently, as the graft is inside the anterior chamber, you can see what is the orientation, and you have to get that correct biceps curl upwards. This is upside down. So one can get it into the correct orientation with the biceps curl upwards. And then as you put the air inside the anterior chamber, the graft gets stuck to the back of the cornea. And this is just to show the post-op picture of the same case. It is very useful in cases of hazy media such as this. In this, the epithelium is being removed because of so that it becomes a little bit clearer. And any tags which are there and any tags which are not visualized can actually be seen with the help of the IOCT. And again, you have to get the same configuration of the biceps curl upwards. And because it is hazy, you can't even see where the S-shaped stamp is, which was put on the graft. But because of the presence of the IOCT, you can actually make out which side is up. And now it is in the configuration is correct by the way the scroll looks. And then this can be attached with the help of the air bubble. And this is the post-op picture. And we published this microscope IOCT guided DMEC in corneas, especially with poor visualization. In eye syndrome also, one can use this. Now, sometimes when there are folds present in the DMEC graft, for instance, in this case, the DMEC was done, the graft was inserted inside, and just as the graft was unfolded and the air bubble was instilled, there is a fold which is there, which is present on one side. Now, if this fold doesn't go even after the air bubble, what one can do is look at the IOCT and actually inject fluid between the graft, between the fold of the graft and the overlying cornea, and then subsequently inject the air bubble from the side. And when you do that, then looking at the IOCT, you can actually unfold that fold which was there, and the bubble can be expanded to get it into the correct position. Now, apart from this, in PDEC also it is useful. And again, the PDEC grafts also we have to prepare on our own because the surgeons here do it in India. And so this is the bubble which is being instilled to fashion the PDEC graft, followed by the injection of the trypan blue dye, and then the graft which is cut with the help of the Vana scissors. Notice that it is a lot more thicker than what Descemet's membrane normally looks like on the IOCT because of the presence of the pre-Descemet's membrane layer. And once this graft is dissected, it is then placed inside the petri dish. And then just like you do in case of DMEC, it is injected intracamerally inside. So again, the epithelium is being removed here, and actually you can make out also that there's an epithelial hump there, and will become clearer later on. If there are any inflammatory membranes, those are also removed, subsequently followed by the desmetorexis, as one would do in a case of DMEC. And a PDEC graft, which is then injected using the glass cannula, and this is placed inside, and it is unfolded with the help of the two cannula bimanually. Subsequently, this has to be manipulated a little bit because it doesn't unfold the way the DMEC graft unfolds because it is splinted by the pre-Descemet's layer, and this is followed by the air bubble which is injected. And this is just to show the post-op picture. The epithelium was debrided, so that is still getting epithelialized. So these are just some of the post-op pictures of the DMEC grafts and the PDEC grafts, which look absolutely clear. So to conclude, DMEC and PDEC combined together have expanded the indications in the sense that we can use all ages of tissues now, and refinements and techniques and modifications will continue to occur. Thank you very much for your kind attention. Benny, you are muted. Benny.
Sorry, my bad. Thank you very much, Professor Sharma, for that excellent talk. We'll move on to our next speaker, Dr. Susan Jacob, who will talk about PDEC. Dr. Jacob. I think you're muted, Dr. Jacob.
Susan.
All right. So thanks very much for inviting me to be part of this talk, and I'm going to keep it, try and keep very much on time. So my talk is on pre-Descemet's endothelial keratoplasty, and I have no financial interest in this topic of presentation. I'd like to say what I did to overcome some of the problems. Three of the techniques that I started using were what I described and we published: e-PDEC or endoilluminator assisted PDEC, air pump assisted PDEC, and host decimetic scaffolding, and also the importance of an IIRSI diaphragm. So just to start off, e-PDEC is basically the use of an endoilluminator for PDEC surgery. This is, you can see a graft inside as seen with a microscope light, and it really has a very poor graft visibility, especially in eyes with corneal edema. It's very difficult to see. Whereas the minute you put an endoilluminator there, you can see how beautifully, and with the microscope light off, how beautifully the graft is seen. You can see the graft in its entire three-dimensionality, and this is because the microscope light comes 90 degrees perpendicular, whereas the endoilluminator light is held from the side. So you can see all the reflections from the graft bounce off with the endoilluminator light, and that gives you very good visibility, very clear visibility. I've never marked a graft with the S stamp or anything, and it's just this technique alone which gives me in a very non-touch technique, without even having to enter the anterior chamber, I'm able to make out the orientation of the graft, and I think that really aids me a lot in my surgery. So that's one technique that I'd like to show you, and this is the post-op of this particular patient, and again just even while it's lying in the medium, you can just see the orientation of the graft even while you're loading it into the injector. So the second technique is the air pump assisted PDEC, and since this is a long video, I'm going to jump it a bit, but you can see it's a complex case because it's got a failed graft, it's got a cataract, and it's got basically some pupillary abnormalities as well, but not too much. So I've done a phaco here. And what I'm going to do now is put in the intraocular lens, and once that's done, we put in pilocarpine to constrict the pupil as much as possible, which may not always happen with these post-penetrating keratoplasty, especially if they were complex size earlier. If required, you can do a pupiloplasty if the pupil is relatively okay, and if the air bubble is holding well, you don't need to do it. But what I want you to notice is the way I'm using that air pump. So I've got this anterior chamber maintainer that's going into the anterior chamber, and this is constantly pushing in air into the anterior chamber. And because of that, I can do a lot of maneuvers without the AC collapsing. You can see I can remove the host Descemet's to the amount I want to. I can use microforceps to go in and grab all the extra Descemet's membrane and remove it. And I can also do the vitrectomy use the vitrector for the PI, and it doesn't bleed from the iris. So I don't have to do a YAG PI the previous day or wait for the bleeding during the PI to subside. The air just tamponades it and stops it. Now here's the graft injected. And you'll see in PDEC, in DMEC, you'll have to be very, very certain that you have actually centered the graft completely. But in this case, PDEC, I'm not, because I know I can center it very easily later, just as I do with the DZEC. You can see that the graft is largely unfolded. There might be small edge folds, again, which I'm not bothered about, because I know I'll be able to unfold it, causing possibly lesser trauma than the DMEC dance would do. So here it is. I've just centered that graft. You can see it's mostly unfolded. There are two edge folds, one here and one there, but you can see with just one movement of that reverse synthi, I've unfolded both of them, centered it perfectly. And this is, in this case, the graft centration is really, really crucial because, of course, there's a failed graft, and it becomes all the more crucial. That's the postoperative appearance of the patient. So the air pump actually acts as a third hand, and it gives you a lot of advantages in doing your surgery very well and being able to do various steps of the surgery. Also, this is the third technique that I'd like to share with you, which is host decimetic scaffolding, which again the air pump makes possible, and also this can be done with both PDEC and DMEC. So here you see the difference that I do is I make the host decimeter axis smaller than you normally would. So normally you would make the host decimeter axis larger than the graft, but in this case I make it smaller than the graft. And then what I do is I inject the graft in and open the graft. As you can see, it's largely unfolded, but there may be a few peripheral edge folds, and I'm going to accept that, and that really decreases my time spent in trying to unroll the graft and center it perfectly, absolutely well. I've centered the graft now. I've unfolded the edges, and next is what I want you to watch carefully, where I remove that graft, that host Descemet's, which was above the graft, to bring it to a position below the graft that's more towards the iris. And so this host Descemet's is actually supporting the graft from below. So this support that the host Descemet's membrane gives the graft from the posterior aspect prevents this graft from detaching. And this is especially important in complex cases. So you can see that host Descemet's scaffolding all around, and this had won the best paper award at the Astros in Washington. We've also published it in the JCRS, and I really like this technique a lot. I'll just show you this phakic PDEC, where also I have used this technique beautifully. You can see there's a Fuchs dystrophy, very young lady. I've done a PI there, and then I've done desmetorexis. In this case, I've done desmetorexis under saline. I removed epithelium over the area of a lot of edema, put in the graft, and unroll the graft. Again, these are all PDEC grafts. You can see that they do largely unfold. The extreme terminal edge folds, do not worry about them. You don't have to be as fastidious as you would do with a DMEC. So there it's rolled up, you center it, just as you can sometimes do with the DZEC, center it. And then this is what I want you to watch, because you know, I've got the air pump going in right there at the inferior aspect. You can see that I can do this very controlled stripping of the Descemet's membrane. I wanted to remove that extra bit of host Descemet's that was there, which I thought I didn't need over there, but watch the amount of control that this gives me. The AC remains well maintained, it doesn't collapse, it doesn't fluctuate. I'm able to do all these intricate maneuvers without damaging the graft or the host. So that's that. And finally, in this case, I didn't remove the cataract because she was a very young patient. I've left in an 80% air bubble, and that's the post-operative day 1 appearance of the patient. You can see very clear cornea and a well-attached graft. So this really is conclude. Yeah, I'm done. This is just 2 pictures, ma'am. This is a normal DMEC and PDEC where you would leave a gap between the host and the graft, whereas here you can see the host Descemet's is actually lying under the PDEC graft. With that, I'll conclude. Thank you very much.
I would now ask the last speaker to speak, Dr. Ruben Berospi, and he's going to be talking about Berospi sign in DMEC. Dr. Berospi, we can't hear you. We can't hear you.
It's a pre-recorded session. Can you guys put the audio? If not, I could speak it again.
Okay. So pre-recorded, please put the audio. No, we can't hear anything. Admin, please put the audio on.
The audio of the video, please. If not, let me share my screen. Please let me share my screen.
We cannot hear anything. Admin, can you please unshare this? And can you please share your screen? Yes.
Hello and good evening. First of all, I would like to thank the Society and the committee for the invitation. My name is Ruben Berospi. I am going to present the Berospi sign in DMEC. I have no financial interest on any of the information presented in this lecture. This is a paper we presented in Cornea in 2019, titled Double Line Reflection Pattern as a Simple Method to Determine the Graft Orientation of Descemet Membrane Endothelial Keratoplasty. As we all know, the Motsuri sign is a sign very well used in DMEC procedure, in which when the cornea is positioned in the correct side, we can see as the cannula enters one of the scrolls, the tip changing colors, as you can see in the blue arrows. This is a very helpful sign. However, we noticed that we also had a reflection from the apex of the cylindrical convex peripheral curves. As you could see in figure A, we have the DMEC graft in an upside down position, and the reflection is very diffuse. In image B, you can see the correct position of the graft, and you can see a double reflection on one of each of the curls. You can see on figures D and F, as you can see in a double scroll conformation, the double line, and in a tricorn hat, you can also see on the red arrows, the double reflection. Even in a tight scroll, you can see the reflection present during the procedure, which confirms the correct orientation of the graft. You can see in this case, as we inject the graft into the anterior chamber, you can see the presence of the 2 lines of reflection showed only with the coaxial microscope. This is a confirmation that the graft is in the correct position. As you can see in the picture from the same video, this is what we call a Berospi sign positive sign, in which you can see the graft with very 2 clear lines of reflection, as we said, the double line reflection pattern, which confirms the correct orientation. This is a video also in which we have the two reflection lines confirming the correct orientation of the graft, but we corroborate it with the Motsuri sign, as you can see. We enter the cannula, and you can see how the cannula tip changes colors into blue, confirming and agreeing with the Berospi sign positive and also with the Motsuri sign being positive. You can also use an endo light from the retina department to find in those opaque corneas, or which doesn't have very much transparency, to confirm the reflection. We use an external light source, or in case you don't have one, you could use the lantern of your cell phone. I would like to also comment as a bonus that we are now using a subretinal fluid cannula, a 38 gauge cannula, to inject air in a very much more controlled way. You can see in the image how this micro cannula enters through the incision with no problems and injecting air more easily than with a regular cannula. Thank you very much for your attention. Have a nice day.
I would also like to acknowledge Dr. Chandra Bala from Australia for teaching us the usage of the 38 gauge retina cannula, and the co-authors of the article, Dr. Virgilio Galvis and Alejandro Tello and Dr. Mahinder Bogal. Thank you very much.
Dr. Benny Jang, I think we will now take the questions for the panelists. Can you start?
Yeah, we're a little short on time, so we can just ask our panelists to each make some comments about any of the talks that you'd like to. Professor Kim, if you're there, if you want to make some comments perhaps on DSO and what the future may lay for that.
Yeah, Benny, thanks for the invitation to participate. I congratulate all the speakers on their wonderful talks. You know, we've had a very minimal experience with DSO, but I definitely think it is an option that's great, especially for folks who you know are a little worried about all the issues with the transplantation in terms of rejection, medication use, positioning, etc. Even though as an active DMEC surgeon, I feel like these are small issues, but to the patient they may not be. Catherine, I just had a quick question for you. You know, we reported in AJO our early series of Nutarsadol associated, you know, reticular this bullous epithelial edema you get. Have you seen that when using that Nutarsadol in your DSO patients? Just curious.
Yeah, I haven't used Nutarsadil. I have just used Riposidil, and I haven't used it. Patients get it, and I observe them using it. It's a classic finding with Riposidil. I would say not 100% of people get it, but probably 75%, and it resolves as the endothelial cells migrate.
Right. Okay. Thank you.
Great, thank you. Professor Dang, wondering what your thoughts are on DMEC and your techniques. You know, we heard a great talk about how to figure out if the graft is the right way, but what do? You do a lot of DMEC. What is your preferred technique to figure out the orientation?
Thank you for the invitation to participate. I use the blue cannula sign with Motsuri sign that Dr. Berospi mentioned. In my patient population, the patients normally have very severe corneal edema. Literally, you can barely make out the iris, the margin of the iris. So for the light reflex method, it's almost impossible to see the graft even. So due to that limitation, I normally use the blue cannula sign, and I think it's a very good technique. I think it is underutilized, and people are afraid with insert a cannula inside the eye, but actually this is one of the most valuable techniques that I have learned. So that's the method I've been using. We do have intraocular OCT. I do use it occasionally, but when I unfold the tissue, I normally use the direct manual unfolding, and I don't normally require a OCT to tell me the orientation, even in eyes with a very opaque cornea.
Great, thank you very much. We can get one last comment from Professor Janji on our panel. any thoughts on where you think PDEC sits with the other available options for DSEC and DMAC and all the variations of DSEC?
Thanks, Manny. It was an excellent presentation, set of excellent presentations by everyone. I've never done a PDEC really. I know Amar, came up with the technique, and Harminder's done quite a few of those. To keep things simple, I would say, as you mentioned in one of the slides, you learn one technique and you try and master that. It might sound a bit philosophical, but I'm sure you and Kathy and even Terry would agree that now we're moving slowly from the type of technique we use to how to improve the outcomes, whether that's DSEC, DMEC, PDEC, or DSO. So I think every technique has a place. You just got to select your patients properly, whether you want to do ultra-thin DSEC, and the sort of controversy is there a cutoff line where, in terms of graft thickness, where ultra-thin DSEC would perform as well in terms of visual recovery as DMEC or even PDEC. But I think definitely PDEC has a place somewhere, as long as your patient selection is fine.
Great, thank you. Professor Sharma, any last comments before we adjourn here?
I think it was a great session, and nice to see all friends from all over the globe. Sophie Dang, I've seen her DMEX, myself in her OR. Dr. Catherine Colby, fantastic talk, and all the other talks were really nice. And I think that's it. Would you like to say something, Benny, before you conclude?
No, I just wanted to thank all of our speakers, the panelists, and my co-moderator, Professor Sharma, for an excellent session today, and I hope you guys enjoy the rest of the meeting.
Thank you.
Thank you. We'll have going to see a small sponsored video, and after that we can start with Dr. Amit Powal.
Thank you, and welcome to the glaucoma session. It's my pleasure to invite all the panelists. I don't want to waste much time in inviting each one of you, but welcome to the session. We'll go directly to the first talk by my good friend, Amit, who will be talking about combined surgery, combining cataract and a trabeculectomy. Yes, Amit.
Thank you, Dr. Venkatesh sir, for the kind introduction. I'm going to talk on combined surgery, that is cataract combined with trabeculectomy. Need financial disclosures, and what we'd like to know is the indications why a combined surgery to be done and when it is indicated. Basically, cataract should be there, and in a glaucoma patients, when there's failure to achieve target pressures by medications, issue related to compliance and adherence to medical therapy, adequate IOP control but significant drug-induced side effects, borderline control IOP, disease progression on near maximum medical therapy, and advanced glaucomatous damage. So there are basically two techniques to perform a combined surgery. You have a single site technique and the twin site technique. So single site, you can do an SICS or phaco plus IOL and trap. And twin site, you have phaco plus IOL plus trap. Now, coming to these procedures of both combined single site and two site, I'm going to show both the videos simultaneously, the SICS with IOL and phaco with IOL because of paucity of time. Now, we have to remember that we need to take a superior rectus bridle suture or a corneal stage suture without damaging the conjunctiva or any vessels when you're taking the stage suture. Always mark your conjunctival flap before you perform a surgery. When you're doing an SICS trap, I usually mark 6 mm on the limbus. And when I'm doing a phaco trap, I usually mark Yeah, when I'm doing phaco surgery, I usually mark about 3.5 to 4 millimeters on the limbus, and I usually make a triangular flap. So before you start within the flap, you have to cauterize the bleeders. You should identify the bleeders and then cauterize only the bleeders. You should use gentle cautery. You should be very careful not to over cauterize, because if you over cauterize the tissue, when you make a scleral flap, there will be flap shrinkage and your flap will get retracted. So always do adequate cautery, never overdo a cautery. And if you want to use a anti-metabolite like mitomycin, you always use a wet sponge, never use a cotton swab to use the mitomycin. There are a few pearls I'm going to share with you when I'm going to talk about this combined surgery. So my preferred technique, as I told already, it's a triangular flap. So with the help of a 15 number blade, make triangular flap. And the trick to get a good flap or even flap is that you pull or stretch the apex of the triangle of the sclera, pull it anteriorly or superiorly in the air, and just touch the edge of the cutting side of the 15 number blade. So once you do that, you get a uniform tunnel, uniform scleral flap. So this is the trick to make a uniform scleral flap. Now once you've made the scleral flap, if you're doing an SICS trap surgery, once the scleral flap is made, you can proceed in the normal SICS surgery, what you are used to doing it. That is, use a crescent blade and make both the lateral horns. Whereas when you're doing a phaco trap, if you're doing a twin side phaco trap, once you've made the scleral flap, then you have to switch your position temporally to do a temporal phaco. So what I usually do is I do a superior phaco, superior trap, and a temporal phaco. So that once the scleral flap is there, then you can proceed to your normal cataract surgery. And due to the paucity of time, I'm not going to show you the cataract procedure. I'm just going to show that how you are going to make the trabeculectomy and how you are going to suture it. So now in this video, you can see that in the SICS trap video, the superior video, you can see that I've made the sclerotomy with the help of 11 number blade. So you can use a 11 number blade, or you can use an MBR, or you can use a Kelly sponge, whichever instrument you are comfortable with. With this instrument, you can make an internal ostium. Once the internal ostium is made, a superior peripheral addictomy is done with the help of a Rames forceps and the vanas. And once it is done, you form the AC with the help of an air bubble. And then you put the scleral flap sutures. Now the scleral flap sutures, you can put all releasable sutures, or you can combine with the releasable suture and an intermittent suture. So when I'm doing an SICS trap, I put one apical intermittent suture and then two releasable suture on either side of the triangular flap. Whereas when I'm doing a phaco trap, I put just one releasable suture, at the apex, and that's how I'm going to do. Now, how do you put the releasable suture? Basically, you can see in this video now that I take a limbus parallel suture is passed into the clear cornea, and then this 10-0 suture is passed perpendicular to the limbus. Once it is passed perpendicular to the limbus, the same suture is then passed through the scleral flap into the intact sclera. So now when you do that, you see that when I'm doing this, there's a loop created over the scleral flap. So now you have to take 4 throws and pass these throws over this loop. So by this way, you're tying a shoelace pattern suture, and this is how you are going to put your releasable sutures. So you can put one releasable on either side, and then you can titrate post-operatively whether you want to release the releasable suture if at all, and if you want to release, whether you want to release one suture or two suture, and you can always titrate post-operatively. Now closure of the congenital flap is very, very important. You have to use an 8-0 white drill and always use an anchoring suture at the limbus. So you take a bit of episcleral tissue or the limbal tissue and anchor the conjunctiva so that the blood doesn't get retracted. So either side, two sutures are put on the congenital sutures, and you have to make sure that the conjunctiva is taut over the limbus so that there is no any post-operative leakage. So this is how you are going to perform this combined surgery, basically a trap. And when you're doing the phaco trap, as I told you, you do the temporal phaco first. Once the phaco is done and the iron is injected, put air bubble or a visco, and then again shift superiorly and continue your trabeculectomy as I discussed already. So the other short clips I'm showing you how to perform the basically trabeculectomy is, if you're doing a straight incision SICS, you can do the normal SICS what you're used to making the straight incision. Just make sure that the incision is placed posteriorly, and with the help of trabeculectomy, the Kelly sponge, you can cut the trabeculum meshwork and then do the peripheral addictomy. And you can put a releasable suture, one releasable, one intermittent, or both the releasable sutures with this tunnel also, and can this is how you can make the trabeculectomy using that. So
okay.
This is what I wanted to talk about. Thank you.
Thank you, Amit, for nicely covering the basic topics. Can you close the screen? Okay, thank you. So I'll quickly get into my topic now. Why minimally invasive glaucoma surgery? It's something which we should explore at this point of time. I'll just tell you why, because like what Amit was showing, Amit is an excellent surgeon, but a lot of times we have unexpected outcomes. As a result, there is a negative marketing for it, and a lot of bleb-related complications. So we need a high safety profile, which is less invasive and a quick recovery. So people look at a lot of options, and at this point of time, it would really benefit open-angle glaucoma, ocular hypertensives, early glaucoma who need cataract surgery, and also people with ocular surface disorders who can't use glaucoma medications or other laser procedures, which doesn't work for them. So when you take a mix, I think there are several options available at this point of time. One is to increase the subconjunctival damage, but the more important is enhanced Schlems canals. So you have several options for that. Even in India, you have trabectome, you have eye stent coming up, you have gonio-assisted transluminal trabeculotomy, and also Kahook dual blade. And the other option is to go suprachoroidal. Many of them have come and gone, including CyPass, which is already out. And another good option is ECP. Some of the surgeons do in India, but again, it needs an expensive equipment, but it's very viable. So at this point of time, I'll just focus on some of the things which are available at this and we can do. One is the gonio-assisted transluminal trabeculotomy. So basically here, what you do is, you do it with an iScience catheter normally. So catheter is very expensive. So alternatively, there is a low-cost option which you can do with a suture. So this suture is a phioprolin which you use. So identifying the Schlems canal is the key here. Once you identify the Schlems canal, you make sure you do a nice intraoperative gonioscopy. It's good to learn intraoperative gonioscopy for any phacosurgeon now. Angling the patient and putting the Swan-Jacob lens and then tilting the head to one side, and then you open up the trabecular meshwork with your MVR blade, and you can see the blood oozing out because of the reflex. And then you use this prolin suture, which goes into the trabecular meshwork, which goes into the Schlems canal. And then you go roughly around 280, 290, or even it can come 360 degree. Now, if you do a good job, you can even make it to come on the other side. And then you do 360 degree trabeculotomy. So in between, we can go and see, but you need a different lens to see in between where it is exactly. If it's a catheter, we can see the light blinking, but here we may not be able to see. But once we do the right thing, I'm sure anatomically it goes around and then it comes perfectly on the other side. So there is a little bit of learning experience, but once you learn, the technique is much comfortable, and you see it comes on the other side, and then you gently pull from either side so that you do a 360 degree trabeculotomy. So this is a viable option which is available, and soon we may get a Kahook dual blade because it's marketed by the same new medical company which makes your Ahmed glaucoma valve. So basically this kind of completely removes trabecular meshwork, so there is less fibrosis and better outcome. I'll just again quickly show you what does the blade do. So it's an animation from the company basically. So the blade is so neatly designed in such a way that the sharp tip easily penetrates the meshwork, and it creates a kind of a ramp effect, which lifts and stretches the meshwork, and it beautifully cuts without much damage to the surrounding tissue. And the excess tip is kind of meshwork is removed by the knife. It gets rolled inside like that, and so that you can nicely remove off the trabecular meshwork and open up the Schlems canal directly to the anterior chamber and control. So this Kahook dual blade, if it is used properly, we can use it for a few cases. The other option which we are trying out is called bang. You can just bend a 23 gauge needle and do something similar to Kahook dual blade. It may not be as good as a dual blade, but it works. So there can be some fibrosis, but you can do additionally certain clock hours to get the same effect. So we can start practicing even by bending a needle like this, and then prepare ourselves for using a Kahook dual blade and other techniques. So to make it simple, I would say MIX has got a very good role, but we need to start practicing intraoperative gonioscopy and do some of these low-cost options and keep us ready for the next level. And again, thank IIRSI and my co-panelists who are here. And we'll go to the next stop by Dr. Singh. Yes, sir, we can see your slide. Can you put it on slideshow and then?
Yeah. So I'm Dr. Kiranjeet. I'm going to start with the glaucoclaw. I call it HIGS. HIGS is highly invasive glaucoma surgery, something opposite to the previous speaker. So it is a device to treat synechial angle closure glaucoma not responding to anti-glaucoma treatment. So the device is basically based on claws of the iris claw lens. And this is a girl who came to me 3 years back, and she had steroid-induced cataract and glaucoma, and for which she got operated later on elsewhere. And when she came to me, her IOP was 37 with all medicines, Diamox and intravenous mannitol. So what I did was, my primary aim was to open the angle mechanically, which I know it is wrong. I should be using a gonial lens and some specific instruments to open up the trabecular meshwork. But I am massaging the iris towards the center, and I am able to make the pupil small. So resynechia formation is a big possibility. So we need something which does not let them happen. So this is similar to Dr. Agarwal's pupilloplasty, pulling the iris root. So this is the device. This is a ring with 5 claws like you have in iris claw lens. And there is no optic. So through the 5 millimeter incision, this can be 4.5 millimeters to 5.5 millimeters in diameter. So I slip in, and with the help of vertical forceps, I stabilize the device, and I push the mid peripheral iris into the claws forcibly, so that the angle opens up. So the one claw is done, the second claw is done. Similarly, now you can see a black spot at the periphery of the iris root. When I stroke the iris inside the claw, it starts moving towards the center. So that proves that I am able to open the angle at least physically. So I'm done with but this is the first time, and I'm very afraid to do this case. For the 6 o'clock position, I was not able to put a lot of iris inside the claw. So after washing the viscoelastic, I put the air, and you can see it is well retained inside the anterior chamber. So in the post-operative period, the IOP was 15 for the next 8 months without any medicines. But after 8 months, the pressure started to rise once again, and it came up to 28 millimeters of mercury, Hg, with all medicines once again. So I plan to redo. So I did the reinforcement. I put more iris in the claws. So every time I did a procedure, I lost around 200 cells, endothelial cells. So all the so iris is pushed once again into the claws. So it is washed, and in the post-operative period, this is a picture. And now after 2 years of her procedure, her IOP is 11 to 12. Interior chamber is deep, and anatomically the angle is open, there is no circumciliary congestion, no progression of the ectropion uvea. So you can see from what stage I could bring the eye to. And I have done 9 cases till date, and all have been treated, and the IOP is below 20. Thank you very much.
Thank you, sir. It's really an out of the box thinking of putting an iris claw to control intraocular pressure. We'll have the next talk by Dr. Samir, who's going to talk about drug-induced glaucomas, which are quite common because of the number of drugs which are increasing. So to give awareness on the treatment and also managing these patients. Samir?
Yeah, thank you very much. First and foremost, I would like to thank IIRSI for giving me this opportunity. Good evening, all the panelists, all the speakers, and my colleagues. I will be speaking on drug-induced glaucoma. So, as you all know, there are several drugs that have the potential to increase the intraocular pressure by open angle mechanism or by closed angle mechanism. The most commonly seen in our clinical practice is the steroid-induced glaucoma, which can be seen with topical use, but may also be seen with oral, intravitreal, or periocular use. It can cause increase in the intraocular pressure by open angle mechanism, usually within 3 to 6 weeks of topical steroid use. Now, what are the risk factors for steroid-induced glaucoma? It is pre-existing primary open-angle glaucoma, family history of glaucoma, high myopia, diabetes, and some certain connective tissue disorders. Now, I won't go into the pathophysiology of this. The steroids, mainly they increase the intraocular pressure by decreasing the outflow of aqueous through the trabecular meshwork. Now, diagnosis is simple. There is history of steroid use, like in patients with vernal conjunctivitis, asthma, renal transplant patients. The rest symptoms are same as primary open-angle glaucoma. The management is we have to discontinue the steroids. We have to replace it with lower strength of steroids or non-steroidal anti-inflammatory drugs. We have to start anti-glaucoma treatment. Medically, mainly we use beta blockers. Prostaglandin analogs should usually be avoided if there is inflammation. And we can go for laser trabeculoplasty and surgery. These are the list of drugs which can cause drug-induced acute angle closure glaucoma. The risk factors for this are, it is usually seen in patients with pre-existing narrow angles, thick crystalline lens, and plateau iris configuration. It is mainly due to pupillary block, which we often see in our clinical practice due to pupillary dilatation by using drugs like phenylephrine, which we use to dilate the pupil. It can be also seen with drugs like systemic ephedrine, which is used for anesthesia, and other salbutamol inhalers used for asthma patients. Now, this is important sulfa-based drugs, acetazolamide, which we use commonly, topiramate, which are the drugs used in migraines, and hydrochlorothiazide. They induce non-pupillary block angle closure glaucoma. How? They cause ciliary body swelling and choroidal effusion, which causes the iris lens diaphragm to move forwards and thus obstructing the aqueous outflow. So management is simple. You have to stop the drug. In this case, because it is not pupillary block, laser iridotomy is not effective. And last resort is surgery. Thank you very much. Thanks a lot.
Thank you, Samir. It's so important to identify because if you keep continuing the drug, some of these eyes can become blind also. So it's important to get rid of the drug first, especially the one like topiramate. Again, I'd like to invite Cyrus, who's been doing NPDS for several years now, and he's going to share his experiences. Yes, Cyrus.
Hi, everyone. Very nice to be here. Thanks to Uncle Amar for calling me. And we meet again on a virtual platform. So I've been doing non-penetrating deep sclerectomy with mitomycin C about 20 years now. We used to joke that trabeculectomy provides work for the glaucoma surgeon, the cataract surgeon because it generates cataract, retina specialists, and also infection control specialists because later on you might get a bleb leak and infection. So deep sclerectomy entered the firmament of glaucoma surgery around about mid-90s. Let's have a look at a quick video. So basically, this is an instruction video that I show everyone before they start. I always use a corneal bridle suture like this with a single 8-O vicryl, which I will use to close the conjunctiva at the end. So this is a nice economical surgery. I always use mitomycin C in a low concentration. Then you can either make a triangular or a rectangular superficial flap, whatever you're comfortable with. I've done hundreds of surgeries with triangular or rectangular flaps, and there's absolutely no difference in the eventual outcome. Just use your normal cataract knife or a scleral dissector. If you have a diamond blade, well and good, otherwise you don't need one. Just take the superficial flap into clear cornea and open up the deep flap at 90% depth. If you're deep enough, you will fall right into Schlemm's canal like this. And you can see just ahead of scleral spur that Schlemm's canal is open. Now, one very important thing is when you're learning the surgery that you have to go deep enough. If you're too scared and you keep going superficial, you will never be able to open Schlemm's canal with any degree of reliability. And you'll be wondering, why is it that this procedure fails and doesn't work? It doesn't work because we don't dissect deep enough. So first few times doesn't matter if you perforate because you're going to do a trab otherwise. Now, this is called conditioning the trabecular descemet membrane. And now we are going to use a sharp rhexis forceps and peel the trabecular meshwork. This is a very important step. So before peeling was kind of invented or devised, the surgery never worked this well. So you always have to check the flow. If you think there's not enough flow, then you peel again. Because if you just leave the surgery like this, then it's going to be a surgical failure and next day IOP is going to be the same. So you have to see good flow on the table during the surgery. Otherwise, miraculously, the next day, there's not going to be any good flow. So now when you check it with the sponge, that's what is termed as good flow. Next day, patient will have IOP of 3, 4, 5. If the IOP is 12 or 14, the next day means the surgery has failed. And you have to go inside and then convert to a trab or then peel the meshwork. Excise the deep flap with a nice sharp scissor that you have. So far we use all cataract instruments. We're not using anything out of the ordinary. And use that same atovicral suture and put the flap back and close the conjunctiva with a single stitch. So if you do UBMs and you check your deep sclerectomies a few years later, you can always see that there's a visible decompression space. And the 5, 7, 10-year follow-ups, you can still see a decompression space like this. So tips for success is always use mitomycin. Otherwise, these surgeries in Indian eyes are doomed to failure. Dissect deep enough at 90% depth. Never tie the flap back completely watertight because that's not the object of the surgery. We are using a low conjunctival bleb to drain. And always, if the IOP starts going up at 6 weeks to 2 months, use a YAG laser and blow a hole in the trabecular descemet membrane. This is very, very easy. Everybody has a YAG laser in the clinic or access to one and a gonio lens. It doesn't require anything fancy. So that's the end of my talk because we have to finish in 4 minutes.
Thank you. Thank you, sir.
Again.
So now we'll have Dr. Roop, who's going to talk to us about glaucoma wick surgery.
Can I start sharing my screen?
Sure, sir. So the panelists can come up with some questions to any of the speakers. You know, we may have some time at the end, maybe 5-10 minutes.
So this is an innovative approach for glaucoma surgery. When 30 years back I started performing trabeculectomy, I was not happy. I was a sad surgeon. Then I started converting and evaluating my own surgical technique, and I started getting good results. That enthusiasm by that, because I am primarily a cataract surgeon. So I also published in this technique in Daily Journal of Ophthalmology way back in 2004. In 2009, when Moorfield Safer Surgery System got published, I was emboldened because I was already doing some steps which they advocated in 2009, like making Fornes-based flap and not making any side cuts in the scleral flap. They advised making limited side cuts. So emboldened by that, I started further evolution of this technique and conceptualized the idea of supplementing the natural meshwork with the artificial meshwork. So for this, I am using a device which I have named as glaucoma wick. It is made of collagen glycosaminoglycan matrix, and basically it extends from the anterior chamber to the subtenon space. So the functioning is followed by the Darcy's law, which is a fluid passing through a porous material rather than a free flow from an ostium. You can do a very simple experiment at your place to see how the wick works. You can keep 2 bowls of fluid and put a gauge in between. The fluid would start flowing from the top one to the bottom one. And the best thing is that even the edge of the bowl, the barrier of the edge would be overcome by the capillary action. So basically it works both like flow from the porous material and also capillary action. So I just share my surgical technique. I use a specially designed glaucoma speculum where the screw is asymmetrically placed. So basically it retracts the upper lid much more than the lower lid. So I don't need to use any sutures on the superior rectus or in the cornea. Then I make a Forney shaped conjunctival flap. Then cautery is done. Followed by that, I make a partial thickness scleral incision 1.5 millimeter behind the limbus. Then with the crescent blade, the scleral flap is dissected up to the clear cornea. Then intracameral pilocarpine is injected to preserve the lens or safeguard the lens, and viscoelastic to safeguard the cornea. Following which, at the junction of blue and white, I make a full thickness incision, followed which the 2.2 millimeter keratome is entered into the cornea, to the clear cornea. So basically now I have 2 incisions of the trabeculectomy block that is to be removed. Finally, the 2 side cuts are made to remove the trabeculectomy block. Then iridectomy is done, and then 2 interrupted sutures are put on the 2 sides of the scleral flap. Finally, I insert a wick which looks like this. The broader portion of the wick is inserted behind in the subtenon space, and the narrower portion is inserted from the scleral opening into the AC. So you can see the part of the wick inside the anterior chamber and connected with it to the subtenon space. Then the conjunctiva is sutured by 3 metal sutures, and by the end of the surgery, you can always see the flap format. If you have to do a combined surgery at the time of making the 2.2 millimeter incision, you can complete your cataract surgery. The only intraoperative complication which is related to with this technique I have had is that once the wick got sort of broken in between and it had to be removed and replaced. This is the result of the formal study that we did in 50 eyes of 46 patients, and it had all vast variety: juvenile OHG, primary OHG, chronic ACG, pseudophakic glaucoma, post-traumatic glaucoma, post-uveitic glaucoma, steroid-induced glaucoma, and one was resurgery. I did wick surgery in 16 eyes combined with phaco in 21, and in one eye it was IOL exchange with scleral fixation with wick. All eyes achieved post-op IOP target of less than 20. Only one patient had to use 1 drop of topical and prostaglandin analog. The complications: 3 eyes had hypotony, all resolved conservatively. 1 eye had hyphema, which also resolved by 1 week. 1 eye had a upturned pupil, which needed more intervention. 1 eye had a corneal edema, that was the one in which I did IOL exchange. 1 eye had a high IOP at 3 weeks, where I did a needling. These are the post-operative images. It is 3 week post-op. You can see the flap and the wick inside the ostium. This is 6 weeks. This is 9 months. You can see the wick getting dissolved. This is 1 year. You can still see the wick. This is 15 months. You can the subtenon part dissolves earlier. It is almost not distinguishable, but you can still see it in the ostium. These are the results of AC anti-segment OCT. The top one is the normal angle, the below one is the wick. You can see the wick here, PI here, and the lake of subconjunctival subtenal fluid. Another OCT, the horizontal section of the OCT. So what we can do is we can customize it to the patient. We can increase the size of the wick. If you have a broader wick, you would have more filtration. Another option is that you can have a releasable or adjustable suture. Like if you remove this knot, the flow of the aqueous fluid will start to increase. Similarly, one can also do the needling that I had to do with one patient, and the blab starts forming on the slit lamp itself. Now the future possibility is we can customize the porosity of the material to make it more effective. We can make a non-biodegradable wick so that it may have a longer lasting effect, and we can have a combination of biodegradable and non-biodegradable that may be the best of the both worlds. So in conclusion, I believe that this surgery can be done by any cataract surgeon. The advantage is that it is the early hypotony and late failure which deters a cataract surgeon from doing a glaucoma surgery. By using this wick, I am able to avoid the both. And then every cataract surgeon would be sort of encouraged to do glaucoma surgery conveniently.
Thank you.
Thanks for the opportunity.
Thank you, Zar, for being in time. I thank every speaker in this session for being in time. So we have a minute or two before we go to the film festival. So any questions from the panelists, any speakers? We can take, I think, probably 2 questions quickly.
Yeah, I have a question for Dr. Kiranji. The GlaucoClaw thing is, it looks like a nice toy, small toy to me. But how are the long-term results of this, sir? We have been using SFT. It's, I think the basis is the same. Like SFT, you are pulling the iris from the periphery to the center, centripetal force you are applying. So how are the long-term results of this?
Am I audible now?
Yes, sir.
You see, I have been doing for the last 3 years, and the movie which I showed you was 3 years back. And after the cases, all were pseudophakic, all had nearly 360 degrees cynical angle closure, and all are below 20 millimeters of mercury. All are doing well. So I
Can
think
it be done in phakic patients?
no, just the pseudophakic.
Dr. Singh, I think that was an excellent video, but I think a couple of gonioscopy pictures could have been appreciated. One pre-surgery and the other post-surgery to see how much of the synechiae has been released with that claw.
Yeah, I
A
had
couple of pictures, one pre-gonioscopy and one post-gonioscopy.
Yeah. It's a very
For your
nice
next
advice.
presentation.
Yeah. It is there in my other presentation in the other computer.
So I
but
look forward to seeing that. Yeah. And Dr. Venkatesh, I think that was a wonderful presentation, and I think that's what trabeculectomy, the future of trabeculectomy is probably the gonioscopy-assisted transillumination trabeculectomy, and we're waiting for the time that you invent another sharp, slender knife with which we can start doing that.
Definitely.
Yeah.
Are you using the Ologen disc and creating the of design yourself?
Unmute yourself.
Hello?
Yes, sir. Roop. Yes, sir.
Yeah, I make it on the table from the Ologen block itself.
That's what
so
it looks
like. Yeah. So that's why it is irregular. I have been persuading them to make it, but they have not been responding. But I am looking for something else other than Ologen.
In needling with Ologen, because I've been using that Ologen disc that was is it kind of,
I think there's some problem with the
Can't hear you.
audio. people are not able to hear that, but persuading the team is very difficult, sir, unless you have a lot of people to follow you. So you need a lot of early adapters to do that. Then only they will try to modify the size or the shape of anything. So Hologen also will be in a similar situation. Until then, you may have to cut and do it on yourself. So I again thank every one of you. It was a pleasure having everyone in this glaucoma symposium at IIRSI. Even though we missed being at Chennai, it's good that we were all able to meet and make sure that this session happens. Thank you again.
I've been able to see your picture.
Thank you. We can see you.
So last,
lovely lotus though. Yeah,
That's it.
Thank you.
One small request.
Thank you all.
Everyone is requested to join Hall A for the film festival.
Sure.
Thank you.
Yeah.
Thank you.
Thanks,
Thank
Doctor.
you.
Thank you very much. Yeah.
Technical person, is there any separate link for Hall A, or we can continue in this? Technical host?
Stop broadcast.
Samir, any idea how to connect to Hall A?
Yeah. You'll have to use another link, the Hall A link.
Oh, okay.
You have to leave this link and go again to Hall A. Yeah.
Okay.